Hello, everybody, and welcome to the ECMO resource session that we're going to be doing. We have a cannulation session that we are putting together for you guys, and I'm so excited to be here with a colleague of mine. He is an incredible ECMO clinician with a lot of experience, so I'm going to let him go ahead and introduce himself and then get started with the session.
All right, my name is Gregg Delk. I'm an RN by choice. I started out in the Army as a medic and decided to leave and become RN. I've been doing it for about 13 years now, going on 14, and it was a great decision. In ICUs, I originally started out in the ER and somehow found myself in step down, and then I really admired what the nurses were doing in ICU, so I started in ICUs in about 2009. And eventually, through much experiencing and moving, I got into CTICU and recently discovered ECMO about 4 years ago. So I've been doing ECMO for about four years, and it's currently, I think about it almost every day. So I'm definitely thoroughly interested in ECMO and what it can do for people and how it's almost like life-saving, the end all of life-saving. So it's really a great venture that I've started in. So in my current place of employment, there is a lot of confusion on where these cannulas lie in the body. You know, I came up with a slideshow and I do some painting and drawing on the side, and I decided to create this course and these drawings to depict what's going on in cannulation to help the nurses in the unit. And it's kind of blown up to where it's kind of, I think, to help the surgeons get the cannulas in the first time when they put them in. And I think it's kind of helped some of our outcomes, and I'm getting a lot of good feedback for it. So I decided to share it with Nicole. I'm very thankful to be a part of this. And with that, I'll go ahead and begin. I'll show you the slideshow that I've made and go from there. Share screen. All right, so ECMO cannula placement. This is a simple class that I developed just in an adjunct to already ECMO teaching. So it's for people that have already learned a little bit about ECMO, and it's just generally going over where these cannulas are supposed to be, how they look inside the body, and what's actually happening while the device is working. Some of the objectives on the class itself is to explain some of the different types of ECMO, which can help you differentiate between VV and VA. Kind of explain where the sites are when doctors do cannulate. It's mainly adapted for what's happening in my hospital. There are obviously different ways to cannulate in other hospitals, but for the most part, this is what we see and what we experience. I went over this with our cardiothoracic surgeon that was kind of the head of the group at the time, and he approved most of it and actually has an article referenced at the end of the show. And I also went over it with our lung transplant director, who also likes it and actually asked me to teach this to his nurse practitioners, which I was really surprised. But I did that as well, and it's helping them learn ECMO. But I mainly made it for nurses so that we can start finding out what we should really be paying attention to when we do have problems with cannulas and suction events, because I noticed a couple of patients that had been cannulated for VV ECMO, and the intake cannula would be too low, and as low as in like the pelvic veins down there and the femoral veins. And of course, the suction events would be a cause of that. And I was seeing patients get albumin after albumin for 12, 16 hours. And really all what needed to be done was that cannula to be advanced. So I thought this would be a great way to show nurses where the cannula should be so that they could look at the x-ray and tell the surgeon themselves, like, hey, maybe you should consider coming in and troubleshooting these cannulas a little bit quicker. So, and I think it's really helped so far in the unit, actually. And then, of course, it also helps the nurses, everybody pay attention to where the cannula should be is when people are ambulating, because we do ambulate our VV ECMOs when they're a bridge to transplant. And a lot of these cannulas can become dislodged, and they can look up the x-rays and see if they have moved. Let's see, the first cannula that actually can become dislodged a lot is the Avalon cannula. It can become twisted in the body, and we recently got these new cannulas that we started using called Crescent, which is kind of similar to Avalon, if not the same, that we were having problems with for a couple weeks, where they would become twisted, and the outtake part of the cannula would not be facing that tricuspid valve that you see in the depiction. Being that this is over Zoom, I can't really point to any of this stuff, but these drawings look really simple enough. But you can actually kind of look at them for a little bit and kind of understand what's actually going on inside the body. Just with the cannulas themselves, like when I first started learning about ECMO, I thought there was like one hole on one end and one hole on the other, and that was it. But there's actually several holes to help with some of the intake to the machine. And sometimes there's several holes to the outtake of the machine. With this cannula, I think there's just the one that's supposed to be spraying oxygenated blood toward that tricuspid valve. And it also, these drawings can help you understand, like VV ECMO, it's all generated to the right side of the heart. So it's the heart's responsibility to get that oxygenated blood to the rest of the body. Whereas in VA, we're completely bypassing the heart. So you can see that in the drawings exactly where the cannulas are and kind of understand how it's bypassing the heart. So that's the first thing you can do with these drawings is say, hey, you can figure out the difference between VV and VA right from looking at these simple drawings. So again, I want to reiterate that in VV ECMO, the oxygenated blood's going right into toward the tricuspid valve, and the right side of the heart is pushing this oxygenated blood into the pulmonary artery. And then the body pumps it the rest of the way, because it's bypassing the lungs, because the lungs aren't oxygenating the blood well enough. So with this cannula, if it becomes twisted, that outtake part of the cannula won't be facing the tricuspid valve, so the oxygenation is going to not be as efficient. So it's important to make sure the cannula is not twisted. And with the Avalon and Crescent cannulas, when they do place these cannulas, they do it with a TEE ultrasound, and it can be done at bedside now. And what they're looking for on the echo is seeing that spray of oxygenated blood going into the pulmonary artery as efficient as it can. And that's how they know it's in the right place. So if you're having low PO2s gradually and you're increasing the flows and it's really not improving, you and the medical doctor team can decide, that maybe the cannula is twisted. And you can also tell because on the top of the drawing, the red, the oxygenated blood is on top of the deoxygenated blood. If it becomes twisted, it's obviously going to be the opposite. So it's just a lot of little details in the drawings that kind of help you understand what's going on there now, and why it's important to keep the cannulas right where they're at. This is more of a scientific computer animated drawing from the Avalon website, actually, and you can actually go on these manufacturers' websites and see videos of these cannulas working. So I encourage everybody to do that. And it shows you exactly how it's spraying blood right up to the tricuspid valve there. And it's also important to notice that this cannula can become advanced too far in, and then you have oxygenated blood, spraying into the inferior vena cava. That's obviously not going to work well with oxygenation. So there's other stuff that can happen besides twisting. This is a depiction of the most common route, and usually the one they do first when somebody's in ARDS and not doing well. This is fem-fem cannulation. And this is really important to get in the right spot, because you can have mixing where the machine is actually pulling out blood that's oxygenated, so the body's not going to get all that oxygenated blood. So when the surgeon puts these in, he's got to make sure those two cannulas are far enough apart to where that's not happening. And again, it shows a lot of different holes up there to show you what's actually happening with the cannulas. There's not just one hole in it at the tip or anything. This shows you down in the lower femoral veins where sometimes they can cannulate. Sometimes this can be opposite, that outtake cannula can be in the left, and in the right, and the intake cannula can be in the left. It can be opposite. It just depends on what the surgeon wants to do. But this is more commonly where they cannulate when they do this, because that right femoral vein is a more straight route, and helps with the intake of that blood if it's got a direct route to the IVC. And again, when they put on that the outtake cannula with the oxygenated blood, they put it right up next to the tricuspid valve to help the heart get that oxygenated blood to the pulmonary artery. And then again, this one a lot, that cannula can be low in those right femoral veins, and that's when you have a lot of suction events that can be fixed by surgeon instead of saline or albumin boluses. So it's another one that you want to check a daily X-ray to find out where these cannulas are. To get to that lower cannula, sometimes, if not all the time, you need a KB. This is a way to cannulate that Dr. McDeesey, that I used to work with, said was the ideal for ARDS. Lately, I've been seeing a lot of surgeons just jump straight to the Avalon catheter, because they want the patients to get up and start walking like the next day, which doesn't usually happen. But this cannula is a little bit harder to walk and ambulate in, but it can be done. So can the fem-fem as well. I've seen a patient walk for 5 months daily with fem-fems up until he got a lung transplant, and he actually got better and is at home. So you can ambulate with these cannulas, but I haven't seen it too often with this one. But again, with this cannula type, it's got the ideal is 15 centimeters away from each other, so that there's not a mixing. And recirculation of oxygenated blood. This is the Protect Duo cannula. In our hospital, it's not really used for anybody unless it's indicated. And when I say that, it's because it's really only indicated for patients that are having right-sided heart failure. This one is pulled out of a tandem heart package that we don't really use the tandem heart device itself. They just open it to get to this Protect Duo cannula, and it goes straight into the pulmonary artery. So it's kind of skipping, the work of the right side of the heart, even though it still needs some function to get to the rest of the body. It tends to help. So this one's really not likely to become dislodged. It's sutured in, it's in the pulmonary artery, it's really not going to go anywhere. So it's kind of safe in that aspect, but it's expensive to use, and they don't like to use it unless it's absolutely indicated. So you won't see it in somebody has good cardiac function. You're going to see this cannula in somebody that's got poor right side of the heart function. And again, you can see the many numerous little holes in there that help the blood get outside the body and get into the pulmonary artery there. So that was it for the VV ECMO part of the depictions. That's the majority of the cannulas that we use at my hospital. There's probably more ways to cannulate, but that's the most common, and up until today, that's what we've been using. And it's, I'm not going to go over the indications and treatment and troubleshooting of some of the stuff. This is just simply strictly a cannulation and why it's important class. This is so then I start on the VAs. This is the VA fem cannulation. And I guess with this one, they're not really concerned about the outtake cannula or the intake cannula, the venous part, the deoxygenated blood cannula, as much as they are as they are in a VV, because they don't have to worry about mixing. So they kind of stick that cannula all the way up into the atrium so they can get good flow going. And the outtake cannula that's returning that oxygenated blood is going to be put in a femoral artery. Now I got two drawings of this just to show how they would look, but you can put that outtake cannula in either the left femoral artery or the right femoral artery. You won't see something called a reperfusion catheter as much in the left femoral artery as if both cannulas are in the same leg. So I do have the drawing of the next type of cannula in the next slide. That reperfusion cannula is important because you can see that, with a cannula being in that artery, it would be tough to get that blood down to the extremity that it's above. Just recently with the ELSO conference, there was a discussion about this, so that was interesting, where they had a pro and con about reperfusion catheter reperfusion catheter on all patients, and I've always leaned to you need to put that reperfusion catheter in all patients, because I've seen so many patients end up with fasciotomies and loss of pulse in that lower extremity, especially if they're on VA ECMO for over a week. And then the other day, of course, recently, my surgeon excited me and surprised me, and actually made a graft into the femoral artery and just cannulated the graft. So it was shooting oxygenated blood both directions because it wasn't blocking anything, which I thought was, was new and interesting. So I don't know if he's going to do that from now on, but that kind of prevented the need for a reperfusion catheter. But that's something you should always think about with VA ECMO. And I would go over this. I'd go over this in the class to make sure that whoever's taking care of these patients are definitely checking their pulses every hour, and not taking it for granted. So that's FEM arterial VA ECMO with a femoral artery cannulation. Another important aspect with this kind of cannulation is what's going to happen when these hearts start improving. What's going to happen is the heart's going to start ejecting blood against the current of the flow of that outtake cannula, and that creates something called north-south syndrome. And that's always important to watch out for. And with these kind of cannulations, you always want to make sure your patient has a right radial A-line in place, because that's the first and the most likely area of the body that's going to be the least perfused if their heart starts improving. So it's another reason I wanted to show the slide, is to make sure everybody's on the same page in regards to where that radial A-line is. I've seen patients with these cannulas and them having a left femoral A-line, and that's going to be a completely different PO2 than the top half of the body, because they're just pulling oxygenated blood out of that femoral artery line. So it's a really inappropriate place to have to pull a gas from. So hopefully these drawings can help anybody see that. And then I was always curious what central cannulation looked like. I went over this with the surgeon himself that would do these a lot, and he approved this drawing to show where exactly he cannulates. So he just kind of cannulates that aorta straight there, behind the subarachnoid and carotid artery branches there. And the idea, or the advantages of this cannulation is that it's gonna go right with the flow of the heart itself, so you don't have to worry about that north-south syndrome. All that oxygenated blood is going to get to in the body to where it's supposed to be. And of course, the disadvantage of this cannulation is, for the most part, they're always open chest. There's been plenty of patients also that have been closed chest that I've had, where they've just spliced in an oxygenator, where they've created like BADs, and they've just spliced in an oxygenator, and therefore it's ECMO. But I've also seen people with just 2 cannulas and closed chests, so that's less risk of an infection. But it's eventually going to have to be changed, or they're going to have to get a heart transplant, or so on and so forth. So that's the difference between a FEM cannulation and a central cannulation, is the flow of the direction of the flow with the oxygenated blood has changed. And he wanted me to mention some of these other ways to cannulate in the body. I've never seen some of these, but he said that he could cannulate an axillary artery or a carotid artery, which hopefully I never will see. We all know problems with axillary. Anytime there's a device in an axillary artery, there's always a risk of the extremity enlarging and compartment syndrome and stuff. So I'd always like to avoid that, but that's always an option. There's a few times where we've had patients on VVA ECMO because they can't get enough flow. If you're having problems with oxygenation and for whatever reason, anatomical reasons, they can add another cannula in there to help with flow. So they'll do a VVA, where they'll have a femoral cannula and an IJ cannula going towards the oxygenator, and then one cannula and an artery returning that oxygenated blood. And then I've seen the opposite, where it's like a VAA. So there's always other things that they can do, but for the most part, what I've depicted is what are the most common. And that's just some of the references. And then these are some of the things that we can get that can be discussed for anybody who would be interested, or just to think about. And that's it. And I'll give it to you, Nicole.
Awesome. Thank you so much. I love that presentation. And the first time that I saw it, I saw the drawings and I was like, who drew these? These are so cool. And Greg drew all of those. He's a fantastic artist and great communicator when it comes to ECMO and teaching and training. So I so appreciate you going over everything with us today. I had a couple of questions for you just to kind of follow up. Let's see here. I think you answered all the questions that I had. I just wanted to mention, you had talked about the VA cannulation and the axillary artery. And I remember having a patient who was cannulated that way. And I think I took care of him for probably a good 5 days. Every day his arm grew.
Mm-hmm.
Every day. I was like, his arm is growing, it's getting bigger, this is what's going on, we need to intervene, we need to do something different. And at first, they were like, no, it's, nothing's happening, it's okay, we'll just kind of monitor it. And sure enough, he had to be, I think we recannulated him just fem-fem. And that was happening, that exact thing that you were mentioning. So I'm glad you brought that up. So you said you've been a nurse for, is it 10 years, 13 years?
13 years total.
13 years, and you've been doing ECMO for 4 years, which is incredible.
Yeah. Mm-hmm.
What is just a couple of things that you would share with ECMO clinicians and ECMO specialists around the world? Just word of advice, a little bit of encouragement for everybody.
I welcome anybody to that wants to get into ECMO to get into it. It's really amazing, and you can lose sleep over it, learning about it, and to not be afraid to ambulate, because it really works out for a lot of patients, and it's a great bridge to transplant. We've been doing them weekly, so get into it.
And then for preceptors, say somebody, because I know you precept a lot and you do a lot of teaching around ECMO for nurses at the hospital that you're working at. What would you say for an ECMO preceptor who's teaching new nurses how to take care of this complicated, complex patient, this therapy, the device? What would be just some guidance and words of wisdom that you would give for ECMO preceptors?
Oh, I don't know. Start with the safety, make sure they're paying attention to where the cannulas are on the outside of the body so they don't come dislodged. Start with marking where they are, make sure they know what to do if one of the engine shuts down. I've seen engines and heard engines shut down. You always want to start off with the safety stuff first. That little class I did was kind of like an adjunct to what you've already started to learn about what ECMO does. So you can talk about the cannulas and where they are in the body to help with some of the stuff, but definitely go into you know, what ECMO actually is as well.
Hmm.
I don't know. That's all
Awesome.
I have to say.
Yeah, awesome. Thank you.
Welcome.
Um, so anybody who is watching this from anywhere else other than the ECMO resource website, you can view this recording at ecmoresource.com, and it will be on one of the education pages. We'll also have it on social media. You can reference back to. And thank you so much for watching. Thank you, Greg, for being a part of this session. And we look forward to seeing you guys in the future.